Our next speaker is going to be Dr. Shail Vasavada. You could share your screen. He's a dynamic cataract surgeon of Raghudeep Eye Hospital at Ahmedabad and has raised his stand amongst young ophthalmologists of today as a perfection-driven cataract surgeon with his explicit wisdom and surgical leads. He has won Best Video International Awards besides his other multiple achievements. And today he would teach us the skill sets of doing a pars plana vitrectomy for cataract surgery. On to you, Dr. Shail.
Thank you very much, Madam Ramuti sir and Shreyas. It's always a challenge to follow Shreyas's extremely meticulous presentation. At the outset, I would like to acknowledge that we do receive research and support from Alcon Laboratories. So I think this is a scenario that all of us are going to face, a posterior capsule rupture, and it can occur as early as the phase of just starting nucleus removal or nucleus assembly, or it can occur as late as irrigation aspiration. So the key point is that we need to attack the vitreous whenever it presents to us, and therefore we should not delay tackling the vitreous. And the reason why we should never go fish out for a dropping fragment or a fragment which we feel is right in front of us is this beautiful video shared to me by my colleague Dr. Deepak, who's a retina surgeon, to show so many of vitreous attachments that are there around the nucleus. So we just see that fragment right within our reach, just behind the posterior capsule, but what we forget is this tremendous vitreoretinal traction that is going to be created by not actually addressing the vitreous first and trying to attack the fragment first. So I think the first important point we need to know is that the goal of vitrectomy is to prevent acute intraoperative vitreoretinal traction and not to try and salvage the sinking fragment or sinking lens material at any cost. The second goals then come to is to achieve adequate vitreous removal to prevent further enlargement of the PCR and provide a uniform support if possible for IOL implantation. And the basic principles of any form of vitrectomy, whether it's limbal or pars plana, is to avoid doing it in a hypotenuse eye. All the retinal surgeons do recommend to never perform a dry vitrectomy because dry vitrectomy is a lot of traction, and we must give up the technique of sponge vitrectomy, that is using a Vexel sponge and then cutting it with a Vanna scissor. So my colleague Dr. Samresh showed us very beautifully how doing a pars plana vitrectomy has several advantages of draining the vitreous from where it's coming, and therefore the chances of damage to the posterior capsule rupture are further less. And today we'll be discussing on how to approach a pars plana vitrectomy, because that's the main mental hurdle that all of us as cataract surgeons have. So it's important to understand some anatomy that is required for a cataract surgeon, that apart from the lens and the ciliary processes and the zonules, beyond the ciliary body is the area, this is the area where we are going to be approaching through for a pars plana vitrectomy. And if we look at the actual dimensions, it's somewhere beyond 2.5 millimeters up to 4 millimeters. It is not defined in each and every eye to be exactly at 3.5 millimeters. So I think beyond 2.5 or 3 millimeters up to 4 millimeters is a good area to consider pars plana entry. According to the age-wise, month-wise data, for most of us as adult cataract surgeons, it's somewhere around 3 to 3.5 millimeters. This would vary based on the myopia and the axial length, but as a general rule, 3.5 millimeters is a good area from the limbus to start a pars plana entry. Making the pars plana entry is not very difficult as most of us feel. So first thing you want to make sure is that you measure it properly on the caliper, that you are at 3 millimeter and not 2.5 and things. And the second most important is the direction in which you make the entry, whether it's a needle or a trocar. So you don't want to direct it parallel to the plane of the capsular zonular complex, because that can sometimes inadvertently hit the posterior capsule. So you want to actually go in as if you want to hit the optic nerve. So you want to go in vertically and hit the optic nerve. Here what we are doing, notice here that we are going to make two entries. These are not transscleral and then scleral. This is we lift up the conjunctiva so that the conjunctival entry is separated from the scleral entry. So that will help in less chances of a wound get. So we let it go transconjunctivally and then turn the trocar vertically and go with full force as if we want to go and hit the optic nerve. It's important to make sure that the wounds are well sealed, and if you find any hypotony, you must suture the wounds. There is no shame in doing that. So this is the way how you would want to go ahead by entering a trocar. Most of these trocars also come with marks, so you don't necessarily need a caliper. You can use these distance marks on the trocars to mark the distance from the limbus. Again, another important point which all of us forget is once we remove the trocar, it's important to give a counter pressure from where you have removed the trocar, because some vitreous leak may be likely to be coming from that area. Is it necessary to have a trocar? No, of course not. You can always use your lance knife or your regular 1.1 to 1.2 millimeter side port knife. It's good to do a conjunctival peritomy when you're not going to use a trocar and do a cautery in the area where you're going to actually introduce the knife. Measure it then again with the caliper, and then you can use, here I'm using the same 1.1 millimeter side port knife to make the actual entry. And you can use the trocar coming in and out through this, the vitrector in and out through this entry. However, you will need to suture these entries because these are usually not self-sealing. And the little disadvantage of this is that, especially when you have to go for a repeated insertion and removal of a vitrector, the wound is sometimes very difficult to find getting that perfect entry plane. So if possible, if you have trocar, that will be easier, but trocar is not a necessity. And trocar can be borrowed from our vitreoretinal colleagues, because in most of their cassettes, they always get a couple of extra trocars. So keep taking and have a backup of few trocars in your setup. What gauge of vitrector? It depends on two things. First is your machine, what capability it offers. Most of the modern day phacoemulsification machines offer up to 23 gauge vitrectomy. The 25 and 27 gauge are usually reserved in the machines which are designed or designated as vitreoretinal machines. But a 23 gauge vitrectomy should suffice. When we make an entry with a lance knife, it's something like a 20 gauge vitrectomy that we are going to be performing. So smaller is better, and 23 gauge should suffice in most of our situations. It's again another important point, what settings and how does the vitrector work. It's important to know that the vitrector comes in two modes, that is cut IA and IA cut. What we want to do when we are doing vitrectomy is to cut first and then aspirate. So we want to be always in cut IA mode, and your OT assistant must be aware of putting in the right mode, because if you go into IA cut, it will first aspirate and then cut. So when you are in cut IA mode, your foot pedal will work in this fashion. That is, first position will be irrigation, second will be cut, that is vitrectomy, and once it is cut, whatever is in the vitrector, then it will aspirate through the vitrector. Whereas when you are in IA cut, which we would rarely need, we would use this only after vitrectomy if some cortex is removal is remaining in the bag. The first foot position is irrigation, the second is aspiration, and once those things are inside the vitrectomy probe, the vitrector will cut it. So it is dangerous to do an IA cut mode when you are doing vitrectomy. It's always best to be in a cut IA mode. What are the optimal parameters for pars plana vitrectomy? I think there is no one standard number that we follow, but I think it's important to follow these principles to use the maximum cut rate that your machine has. It may be 1500, it may be 3000, 4000 and 5000 with some of the newer generation phacoemulsification systems. You must have a low flow rate, because you don't want to keep attracting too much of vitreous coming from too far down or too much from the periphery. So we like to keep a flow rate of around 10 to 12 cc per minute. Low bottle height. So if you're using 90 bottle height, go down to 50, 60 or 70 at the most, and use moderate vacuum. Around 200 to 300 should be sufficient for a good vitrectomy to be done. So this is just a clinical scenario to show a lower IOP of 30, which is equivalent to about a bottle height of 50 centimeters, a flow rate of 12 cc, 12 to 15 cc per minute, and vacuum here it's higher because we are trying to also gather this fragment that is being removed from the vitreous cavity. So we need to follow these principles, and just a case example to show that once you notice a PCR, to identify vitreous, triamcinolone is the only way you identify vitreous. And although 3/4 of the nucleus is still sitting in the bag, we have to attack and remove this vitreous before thinking about doing any scaffolding or before doing thinking about any removal of the fragment. And notice how beautifully through that tear this vitreous gets sucked in, and now we have severed the connections from the anterior and posterior compartment, and therefore the chances of further vitreous prolapse become very minimal. And once a good vitrectomy is done, even with this large posterior capsule rupture, you can still go ahead and remove the nucleus with less fear of the nucleus dropping. There is more fear when vitrectomy is not done rather than when vitrectomy is done. And therefore must be addressed at the first go. And this, like I said, vitreous this could be at any point. So this is after IOL implantation. While doing a heroic eye removal, a PCR was encountered. And notice pars plana entry was made with the IOL in the back, and notice how this vitreous is getting sucked through this posterior capsule rupture that is existing. And once the connection between the anterior and the posterior is severe, then you go around, then you can cut it from the anterior part to make sure that the whatever is stuck in the incision is removed. Peripheral retinal evaluation is a must, but it's not that it's because it's pars plana it's important, and because if you do limbal vitrectomy you don't need a retinal surgeon opinion post-op. I think whenever a vitrectomy is done, a peripheral retinal evaluation is a must, and keep remembering these patients may be at a higher chance of developing macular edema post-op. So the main question is, how do I adapt? I think the first and most important take-home message is change your mindset. It's only 3.5 millimeters away from where you are used to working even otherwise. Interact with VR colleagues if you have access in your own hospital or otherwise with your friends whom you keep referring even otherwise. Look at videos. I think now there is no dearth of videos and teaching material available freely on the internet. And I think it's good to attend a couple of ORs with your VR surgeons to observe how they approach and the principles that they follow. So I think the take-home message from my side would be change in mindset. Keep in mind the anatomy, where to enter and how to enter. It's important to keep in mind that we don't require elaborate instrumentation. You don't need the most hi-fi vitrectomy machine that posterior segment surgeons use. Always make sure you're in cut IA mode and never in IA cut mode. Have the maximum cut rate offered by the machine. And I think if we follow these principles, we are more likely to improve the safety of the eye intraoperatively having a PCR, and therefore likely to produce better outcomes post-operatively. So thank you very much for the patient listener.
Thanks a lot, Dr. Shail. I just have one small doubt. If it is a small eye, very high group, maybe those are situations wherein you would wonder to do a pars plana approach because the location of the pars plana itself might be a little anterior, no?
Absolutely. So like I said, this is just a general guideline. There will be extremes, like for example an axial length of 34, 35 or an axial length of say a micro-ophthalmic eye and things where it's a calculated chance because nobody really knows where the exact location is going to be. But for an average eye, I think this is what we can follow. But you are absolutely correct. In extreme situations, it may vary by 0.5 millimeter here and there.
Any questions?
Sir, you have to unmute yourself. Ramuti sir, you have to unmute yourself.
Yeah.
No. Sorry. Excellent presentation. I wanted you to emphasize the practical aspects of doing a pars plana vitrectomy because most of us acknowledge the fact that it is needed, but there is a mind block about adapting it. I think all you need is a trocar cannula. And apart from opening up the conjunctiva and having to put a suture, the fact that the trocar cannula also gives you a direction. So that, it's easy not to hit the retina, it's always pointing towards the center of the vitreous cavity. That it's important that this investment is a worthy investment and any reasonable phaco surgeon can easily adapt this technology.
Yeah, I think with the trocar, the other advantage is that if you have to repeatedly keep going in and out with the vitrectomy, it's easy. Because with the lance knife incision, it's difficult to sometimes find your way through all the time.
Okay,
Shail, excellent presentation. Just a few points because now we are teaching our, after Abhay's wonderful lecture, a lot of our juniors also have started. The main difficulty they find is when they're using the trocar, they're very hesitant when penetrating the sclera. So you have to kind of punch it. If you don't punch it, then it doesn't really enter, and then they are struggling to push it. You can't really push it. You have to punch through. That is one point I just wanted to emphasize. And the other thing is that most of these machines, it is so convenient to use a 25 gauge vitrectomy because it's sutureless. But most of the anterior segment machines come with a 23 gauge vitrector, and I've been asking companies, why don't you change it to 25 gauge so that it's much easier. So if you borrow your trocar from your VR surgeon, then you should be careful, because many a time it is 25 gauge and then your cutter doesn't go in and you're stuck.
Very true, sir. Very true.
Valid
Yes,
points.
Gaurav.
I wanted to add on the same lines. In fact, something else beyond what Sri said, that while Shail, beautifully showed those videos, and, his point is so well taken. The thing is that many anterior segment surgeons, they would hardly use the trocar and, this thing once in a few months. So they're not going to be used to the amount of pressure to be used, and, they're not kind of conversant with using it every other day. So one has to be very cautious. Also, if the globe is hypotenuse, he very well mentioned that you have to suture it. But if you have a hypotenuse globe, you may end up creating a mess, trying to push in through. And sometimes if you've borrowed these trocars, or you're not maintaining them well, or you're not using disposable, high quality trocars, if you have a bluntish trocar, you may struggle to actually get it through. So there are lots of things which need to be taken care of. Of course, it's beautiful, and I love using the trocar as well. And the point about the 25 gauge that Shri said, that you have to have the matching, cutters, not the ones with the 3-port. I mean, the uniport 3 things which most of these companies give you. You have to be prepared with it, what you're going to do. And that said, it is not bad sometimes to actually, if you're not very conversant with it or not comfortable with that, going in from 2 paracentesis ports, not from the pars plana, is not something which is, to be looked upon. You can still do a great job using Triamcinolone and making sure you have 2 good paracentesis ports and matching size infusion and cutter, and in a controlled way, if you can use the right settings with low infusion and high cut rates and cut first, you can still do a good anterior vitrectomy in the area and still get away. If you, it's not like it's absolutely necessary to go through the pars plana. Yes, if you can do it with the right instrumentation, you must do it, and it's obviously better.
Absolutely, sir. Points well taken. In fact, Dr. Steve Charles, we do a course together at ESCS for the past 3-4 years, and he always tells us that as cataract surgeons, it's best for you to use a lance knife rather than a trocar, because the kind of amount of force that you require with a trocar is much higher than with a lance knife. So he in fact always recommends that, as cataract surgeons, those who have never used a trocar, do pars plana, but do it with a lance knife rather than with a trocar. It's easier to make the entry.
I may add here, because I just forgot to add one thing. There are very good quality trocar sets available at very cheap prices, disposable ones from several manufacturers now, and one can practice using the trocar even through the limbal approach. Initially, if you don't want to try it through the sclera, you can actually use it like a trocar AC maintainer kind of a thing. I use something from money. I have no financial interest. It's a cheap thing which comes with 3 disposable things, and you can practice it if you want, in your routine cases to see.
Thank you so much, Gaurav. Very important points made out, and I think it's extremely important for us to ensure that it's not a hypotonic eye in which we are trying to make an entry. That's when you end up in problems. And secondly, as Gaurav emphasized, I think it all depends upon the stage at which you have to do an anterior vitrectomy. If it's just all the nucleus is out and during capsular polishing you have a small rent, then if just vitreous pops out, maybe with the Triamcinolone staining, even an anterior route will be good enough. But for the kind of cases that Shail showed, where most of the nucleus is still there and we have a admixture of vitreous and nucleus, maybe going through the posterior route would be the right way.